Hi, I would like to welcome all of you to the Society of Skeletal Radiology Resident Education Club webinar on postoperative appearance of common upper extremity surgeries. My name is Mariam Gulshan. I am a musculoskeletal radiology at University of California at Irvine, and I will be serving as the moderator for this session. It is my great pleasure to introduce our speaker for this webinar, Dr. Gregory Hall. Dr. Hall received his medical degree from Albert Einstein College of Medicine and completed a diagnostic radiology residency at NYU Winthrop Hospital, and then a musculoskeletal radiology fellowship at Vanderbilt University. After finishing his fellowship, Dr. Hall remained on staff at Vanderbilt for 4 years before joining OHSU in January of 2023. Throughout his medical training, as well as early career, Dr. Hall has earned awards in teaching and was selected for mentoring fellowship while at Vanderbilt. Dr. Hall is currently the fellowship director in OHSU and excited to share his love of teaching with all the trainees at OHSU and now in SSR Resident Education Club. He's an active member of society and a rising star in radiology. Just a quick reminder, if there was any question, please put it in the QA box and we will discuss them at the end of Dr. Hall's presentation. Now, with no further ado, let's give the podium to Dr. Hall.
Thank you, Miriam. Right. Welcome, everybody. Good afternoon, evening, depending on where you are throughout the United States and beyond. I'm really looking forward to going over some postoperative MRI findings, radiographs. We're going to go through it all. A lot of this stuff is not what you kind of cover on a day-to-day basis in the reading room, and I really want this to be more of an informational thing, just kind of gathering information as we go. Sometimes things aren't on the test that you want them to be on the test, and sometimes they are. Let me get started here. I have no disclosures. So this is kind of my slogan that I picked up my first year in medical school. Our anatomy teacher was wearing full body spandex, and he stood up on his desk in this big auditorium and he started kind of explaining to us about the skeletal system and things like that. But before he got started, he put a slide up that said, accept ambiguity. And as a first year medical student, that's like the last thing you want to hear. You want answers, you want all these things. And it took me a while to kind of wrap my head around that idea of ambiguity and learning to accept it. But you're kind of forced to as a radiologist. There's so many versions of normal, and you just kind of have to figure out what in this kind of gray world is pathology or not pathology. And I feel like accepting ambiguity kind of takes away that concern about always being exactly right about something. And there's just no, replacement for experience. Hopefully you guys recognize Mark Twain, but I absolutely love this quote because I kind of feel like he probably learned this as a kid. A man who carries a cat by the tail learns something he can learn in no other way. And if you don't believe him, go carry a cat by its tail. All right, goals. So this is not a how to diagnose labral tear or how to diagnose a re-tear of the labrum. This is more of just, what are these kind of weird procedures that we're doing? What does it look like after the procedure? And what can we kind of do going forward with each of those things? And then, just becoming familiar with what is the thought process behind doing these surgeries. We're kind of isolated sometimes from orthopedics and other surgical specialties, and you kind of need to talk with them and figure these things out. And it's really important in how you kind of manage these patients going down the road. So we're going to start with the shoulder. Tons of surgeries are related to the shoulder. We've got lots of imaging. We see the shoulder all the time. It's kind of we got three big bones. You got your scapula, humerus, and your clavicle. One really big joint being the glenohumeral joint. The shoulder has kind of evolved to become this maximum flexibility at the expense of instability. So the more kind of movement that you're looking for, the more likely you are going to dislocate. And some of the stabilizing features of the shoulder, some of them are static, some are more dynamic, but the static ones are going to be your glenoid and your labrum, and the more dynamic stabilizers are like your rotator cuff. And there's lots of ligaments in there as well. So the labrum, the glenohumeral joint as a whole is just a kind of a fascinating structure. You've got this very tiny surface area for the glenoid. And then what we've tried to do is kind of create a labrum that deepens the socket and then that bigger capsule around that. And the goal of all of this is just to maintain that maximum flexibility without causing too much trouble. But because of that, dislocations are extremely common. So a third of all joint dislocations are the shoulder. And it's inevitable when you dislocate your humeral head anteriorly that things are going to be injured. It's not supposed to be there. The tissues are not meant to stretch like that. And so you'll see in studies there's a 90%, reported rate of labral injuries. It's probably higher than that. It's just a matter of, sometimes you get scar formation by the time you go to arthroscopy and things like that. All right. So labral tears. There are books kind of going into each and every single type of labral tear, and we are not going to cover those. Something I like to tell the residents when they're like, perseverating or telling me it's a slap 5 or a slap 6A with a B modifier, I just tell them, just describe it. You can't go wrong describing it. And if the orthopedist wants to plug in all those little details and come up with a slap number, that's fine by me. But what I like to do is just describe. So we've got two, illustrations of tears over here. This is, the colloquial term slap tear, superior labral, anterior to posterior. And then a Bankart, which is just a soft tissue labral injury. But you could also call these tears from the 2 o'clock position to the 10 o'clock position or the 3 to 6 o'clock position. Both work just fine and just the kind of progression of number of slap tears I've seen in my short career is kind of frightening. All right, so what do we do when we tear that labrum? The whole goal is to just reestablish normal anatomy. And by doing that, they can either debride the labrum, sometimes they have to tie it back down with some anchors, but because someone's dislocated once, there's always a concern that this is going to be a recurrent problem. And occasionally they'll have to do some capsule repair where they tighten it up. This is an illustration of that where they've cut the capsule and they kind of pinch it together and then pull it up. And that causes a really tight capsule. You lose quite a bit of range of motion. I know this personally because I had this surgery, and they really just want you to have a frozen shoulder the rest of your life so that you don't dislocate. So it's a balancing act. All right. So what does the labrum look like after they've gone in there with their cameras and their tools and kind of debrided things? It's going to have this kind of heaped up, rounded appearance. It may look a little bit blunted along the edges. It's never going to look exactly like the labrum, but it should have a pretty smooth, regular appearance to it. You may see some fraying along the edges, and that's just kind of expected when you're going in there and debriding stuff and trying to get it back to normal. But it should be tightly bound to the glenoid. You shouldn't have a big separation there. You shouldn't have contrast pouring out of it. And really, it's just going to look like a labral tear after surgery. The same kind of diagnostic findings will be there. So this is a great article I found where they took MR images plus the arthroscopy images to show kind of what they were doing here. So on this first image on the left, we can see that we've got this elevated labrum. We've got contrast going underneath it. It looks like it's a little bit peeled off. There's some posterior labral tearing as well. On arthroscopy, sadly, it's a tiny picture, but hopefully you can appreciate that this is the kind of macerated looking labrum that's being held by some forceps and kind of lifted off the glenoid. And this is what they're going to kind of suture back down and repair. And that's what it looks like afterwards. So you can understand that postoperatively, you're going to kind of have a little bit more of a rounded, lumpy appearance to it, but contrast should not be getting underneath that labrum. You really want that to be as close to the native labrum as it gets, and a little bit of fuzziness is okay, but if it's really looking wonky, it's probably retorn. Okay. So here are a couple more images from that article, and I'll share all these articles with you at the end. I came across several that I found to be just really great, and they're now in, everybody's favorite article folder on their desktop. So here we've got that same person showing the tear followed by repair, and now we've got a repeat injury of that anterior labrum. So it looks exactly like what we would expect a torn labrum to look like before surgery. It's peeled off of the glenoid. It's got this big cleft in it, filling with contrast. They went back to surgery and it just looked horrendous in there. Lots of frayed tissue. It just kind of came apart. And then this is just an example of a horrendous re-tear. I mean, it's hard to know that they even had surgery to begin with. But the labrum isn't the only thing holding the humeral head in place. You've also got the glenoid, and it sometimes is also fractured or displaced like this. So this is a case that I just saw last week, actually. This guy dislocated and broke a giant fragment off the front of his glenoid. And that creates a lot of problems because once you've lost that glenoid surface area, you are going to have recurrent dislocations, lots of instability. And there have been lots of articles looking into this as to what percentage of bone loss is, going to lead to recurrent instability. How does the glenoid and humeral head track? And it gets into a lot of kind of complicated mechanics with all of that. But the big thing to just remember here is that if you've lost a big portion of the surface area, you've become more unstable. And this is a CT showing that big, horrible fracture of the glenoid. I love sharing this picture of these two cadaveric shoulders because these are shoulders that I had to deliver to I was in New York and I had to take them up like 30 blocks to get them to the MSK reading area. And they're in a big giant cooler, and I didn't want to just drag them up there or carry them, and so I took a cab. And the guy asked, "What's in the cooler?" And I said, "Some shoulders." And he laughed like I wasn't serious and dropped me off and said, he said goodbye. I don't think he really ever knew that I had cadaveric shoulders in that cooler, but it was just, the good old days of running around with cadaveric shoulders. But what we did here is we took the glenoid and we shaved off the front of it to make it basically a big osseous Bankart injury. And kind of looked at what percentages and things like that will lead to increased instability. And there's a bit of a range and there's some, contention about what is considered significant. And that ranges from about 17 to 25% of the surface area. 20% in my experience has been kind of the, right in the middle number where people are comfortable with that. But you also have to take into account what degree of the labrum has been injured and all these other things. And so it's not just, you have 17% glenoid bone loss, you're going to glenoid augmentation. It's, there's always multiple factors going on here. So one thing that we can do with a big osseous Bankart injury like this is just do a primary internal fixation. This person was very lucky that their pieces were like puzzle pieces and could just be kind of put back together and a single screw was used. But more often than not, that osseous Bankart fragment will be just destroyed and it'll be little bits of bone in there, nothing that you can really reconstruct. And so that leads us to two of the more common glenoid augmentation surgeries. And the Latarjet and Bristow procedures are very similar. It's a little bit different in how they attach this coracoid, but the bottom line here is we're trying to increase the surface area of the glenoid after losing that anterior rim. And what you do is you take the coracoid process with the tendons that's still attached to it, and you transfer it down to the front of the glenoid and you put a couple screws in there. Sometimes you'll see it with a single screw going through. I don't know if any of you ever tried to build a tree house growing up and you put the pieces of wood into the trunk of the tree with one nail and you go to step on it and it spins. I think someone figured that out along the way, and now we started putting two screws in there to really tighten it in there. And what this image over here is just showing is that you've got this glenoid bone loss. We've filled that. And so now this big Hill-Sachs defect that they're demonstrating here is not going to get hung up on that. And there are lots of primary repairs of the humeral head to kind of account for those Hill-Sachs deformities. I'm not going to get into those, but basically what they try to do is just fill that gap and restore the contour of that. And there's many different ways of doing that. You can do it with bone grafts. You can actually fill it with tendon. There's many different ways, but we will not get into that. So here we've got an image of the Latarjet procedure where they've screwed that transferred coracoid on. They screwed it in there and it's nice and tight. And then this image over here on the right is showing a very well-healed glenoid augmentation. I'm not sure what type this was. It looks more like a Bristow procedure, but I mean, it's not really a here or there. But what we do is we've got this nice fused osseous bone graft and increased surface area. So hopefully you guys like Bob Dylan or know who he is. One of his lines is, "When things go wrong, so wrong with you, it hurts me too." And that is how I feel about the Latarjet. When things go wrong, man, they go wrong. They never fail in a subtle fashion. The screws are going to be bent. Sometimes the screw is just like migrated into the superior joint recess. And it's one of those where you pull up the x-ray and you're like, ooh, that doesn't look good. Like this one, for example. You can see the coracoid process, the graft that they've taken, broken lag screw, and it's just kind of creeping its way out of there. Again, not a very difficult diagnosis to make. These usually let you know that they have gone bad. Okay, a little bit about rotator cuff. This was always a hard concept for me, and personally, I still feel like the shoulder MRI is one of the hardest studies to read. It's one of those things where like, oh yeah, I'm going into diagnostic or general radiology. I want to read shoulders and knees. And I'm always like, I get the knee, the shoulder. I don't know if I'd feel so bold about just being able to read shoulder because there's so many variables that go into imaging of it. And also just the tears can get very confusing. Common indications for repairing the rotator cuff are a high grade or a full thickness tear, along with pain and functional deficits. You'll find people that have these horrendous tears and functionally they're doing okay. They don't have lots of pain, and it'll be a massive rotator cuff tear. But if you've got pain and functional deficits, good reason to go in there. Some contraindications to going in and fixing it. One would be a high riding humeral head with lots of osseous remodeling, and then rotator cuff atrophy. This is something that we love to talk about. But there's a little bit of a difference between atrophy and fatty infiltration. If you've got someone that just has small muscles like myself, those can grow. But if you've got fatty atrophy, you're kind of lost. So the fatty infiltration is much more concerning when you're going in and considering doing a rotator cuff repair. Okay, so here I just wanted to show a few different types of cuff tears. Um, this one's an articular sided tear that's retracted. We've got a tiny bit of kind of granulation tissue holding a piece of the tendon still there. Here we're getting a lot of bursal-sided fraying from the chromium and then a nice big full thickness tear. Okay. So I wanted to make sure to include these three images because this is, I feel like, a point of confusion for a lot of trainees. It's the whole idea of the bursal versus articular versus interstitial tear types, particularly at the footprint over here. Because you see something that's touching the bone, you're thinking, oh, that's going to be articular sided. But I try to explain that you need to think about it more along the lines of where the ports go in with their cameras for the orthopedist. So they're going to have one that's on the bursal side, one in intra-articular. And if you try to imagine looking at that tear from that position, you're trying to figure out, am I going to see it from the articular side or the bursal side? And so this one goes all the way through the footprint to the articular surface. And so if you put a camera in and you looked up this way, you're going to find that tear. Similarly, a bursal-sided defect you won't see from the articular side, but with that bursal-sided camera port, you're going to see all this fray. This is the one that's tricky because it's hidden from both the bursal and articular side. And the point of confusion is when it's kind of touching the bone here, but you still have intact fibers over here. Deep down, you want to call that an articular sided tear because it's touching the bone, but it's still within the footprint and would be invisible when you put your cameras in there. So these ones really do require a little bit more wordsmithing and description than low-grade bursal-sided tearing or low-grade articular-sided tearing. These ones you kind of have to describe the size of that big tear in there and whether or not you have any bursal or articular-sided fibers remaining. Typically, it's a high-grade tear with just little paper-thin fragments on each side. And then these are the correlates for each of these. So this is our articular-sided tear. The articular fibers are completely torn over here, and it kind of delaminates. This is purely articular-sided. And then this is the interstitial tear, or this is basically a hidden tear because you're not going to see it on arthroscopy. I had to include this one for a couple of reasons. One, it's got the greatest name for a rotator cuff tear. And two, the guy it's named after is from Portland. So this is called the Fosbury flop tear. And it's when these bursal-sided fibers tear and then flip back and double back upon themselves. So you see how it kind of goes and then it's curled? That's the torn tendon stump all the way back there. And the reason it's called the Fosbury flop is because this guy, and hopefully you know this history and I'm just going to tell you it anyway. This guy was really into doing the high jump, but at that time, the only way that people did it was jumping kind of with their belly over the bar, and they would try to land on their feet. And he just could never figure this out. And so he started doing it this way, where he would run up, jump backwards over it, and started breaking records, like became an Olympian. And this is what we now know as how you high jump. It's the Fosbury technique. So if you ever see that, you got to throw out Fosbury flop. I'm not big on names of things. I try to avoid them just because I like to be descriptive and explain what I'm dealing with. But when you've got the chance to say Fosbury flop, you got to take it. Okay, so I found some intraoperative images to kind of look at and get an idea for what we're dealing with postoperatively when we start looking at these shoulders. It gets pretty messy in there with those cameras. It's a tiny little image that you see. So you kind of have to figure out, what am I dealing with back here? We've got some glenoid. This is the footprint of the torn tendon on the humeral head. And this is some retracted rotator cuff. So now he's kind of grasped this big tendon stump and he's pulling it back. He's going to put an anchor in the humeral head with these sutures, and they either perform 1 or 2 rows of these sutures along that humeral head. In the end, they want it to look something like this. It's just kind of cinched down. You've got tons of little holes going through it. And that is actually part of the healing process for this. The double row technique has been found to be good because there are more holes drilled into the humeral head, and that creates more vascularity. And so it's not so much that you have more sutures in there or you've repaired more of the tendon, it's that you've basically poked more holes in the humeral head to allow for healing. But before we go on, just looking at this, you know that's not going to be pretty when you do a postoperative MRI. I mean, that's not a good looking tendon. It's fixed, but it's not pretty. So the normal postoperative appearance is this very heterogeneous. There's always susceptibility artifact all over the place, from the little bits of metal that get shaved off or little, clips that they've put in there. Sometimes the anchors they use have lots of susceptibility in them. And half the time you can't even tell what you're looking at. But the fortunate thing is we're really just looking for giant full thickness retracted tears, because the cuff is never going to look normal again. It loses its watertight capsule, so fluid is constantly leaking out and making you think that there's some big tear. But it's very difficult to figure out which way, what you're dealing with when you have these very distorted looking repaired cuffs. As far as outcomes go, a lot of people stay symptomatic after their surgery. And that can even be with a cuff that remains intact. They just still have pain. There's a large range of rates of repeat tearing. 11 to 68% is what you're going to see in the literature. Anytime I see a range like that, it just tells me that there are so many more variables that we're not including in this. Surgical technique, the state of the tendon, you can't control for those things, and everybody's a little bit different. And this kind of goes back to that. You have to accept ambiguity. You don't know what that tendon looked like when it started, and so you kind of have to be very careful as you go through that. This is not a diagnostic dilemma. We know we've got these huge recurrent tears in it, and that is typically what you're going to see postoperatively with a re-tear. This kind of scary looking, amorphous, thickened appearance, that's all okay. But a big full thickness gap, that's when we know that we've got a recurrent tear, especially if you look at where they put these anchors. So this is an example of a double row where they put a set of anchors on the far outside, and then there's another one here, and that's where that tendon stripped back from, is this medial row. And this one is still keeping kind of the outer edge of the cuff intact. This is a complete full thickness, full width recurrent tear. Well, there's sometimes questions about arthrography and why you would do that after rotator cuff tendon repair. It doesn't there isn't a good answer here. There's not a good explanation for, when you should do MR arthrography. It's all kind of case by case in your problem solving. When you've repaired the cuff, like we discussed, it's going to be heterogeneous, it's going to be distorted, and partial thickness tears are going to be impossible to kind of differentiate from just the distorted tendon after repair. Occasionally, you'll get these intermediate signal abnormalities in the tendon, and you're trying to figure out, am I dealing with scar or is this a tear? And in those cases, sometimes the contrast will fill that gap and tell you that it is a tear. But again, that kind of goes back to the tendon just always looks a little bit distorted. So these low-grade partial thickness tears, it really are not helpful. It's not helping the surgeon if I tell them, oh, I think there's a new tiny tear here or over here, because it's just, you can't really differentiate those things. It's really high grade, full thickness. That's where you're kind of landing with these postoperative MRIs that you're going to see. And it's, they're not pretty and they always look a little bit scary. And then I also found in my research on this that sometimes you can have a full thickness tear that you can see on the MRI. And then if you do an arthrogram, all of the contrast will stay in the joint just because of scar formation that happens. So it may, MR arthrography is not going to be the gold standard for diagnosing things. It's more of a problem solving tool that we can use. All right, I'm gonna do a little bit of elbow stuff before we get to some Q&A. The elbow, I absolutely love the elbow. It's like, I feel like it doesn't get its time in the limelight. It just has so many crazy ligaments in there, and you've got these weird rotating bones, flexing. They just move all over the place. And, it tries to stay put, but people tend to just really hurt their elbows and they fail. As I was preparing this, my 11-year-old came in and saw the word sigmoid and has not been able to let it go. He's really into the whole Sigma stuff, and I regret ever letting him see that image. So the reason I included these images is really just to recognize that all of these little things that they're pointing to, more than just knowing what they are, these are all ligament and tendon attachments, and they're all critical for what we look at on MRI. The sublime tubercle, it kind of feels like this little esoteric anatomic thing, but that's where the UCL is, and that's where we're going to see changes after surgery, after injury. So it's important to know all these things. It was ironic that I got feedback from a different course I had done, a different lecture I had given to PA students about basic anatomy, and the one critical review that I got was that they didn't need to know the attachments of muscles. And so I just found that pretty funny. That was her critique, is that they don't need to know attachments of muscles. So, but we do. Radiology does. All right. No discussion of the elbow is complete without a couple of pictures of pitchers, just because this is unreal, the way that they've figured out how to whip their arm at such a rate that they can throw a ball 100 miles an hour. And there's books, many articles about this whole throwing phase. I don't want to get into that, but the big thing that we just need to remember here is that they are putting unreal stress on their UCL, because you can see that how much of a valgus stress what we're getting with the elbow here. And, that is a very high risk for tearing that, and very problematic if you're a professional pitcher. So the UCL has these three bundles. The transverse bundle is just kind of it's just there for show. The anterior and posterior bundles are the ones that we really are concerned about. The primary valgus restraint is the anterior band, but you got to have the posterior one there too. So here are three different UCL tears. It goes proximal, mid, and a distal. the T sign that radiology loves to talk about and discuss is not the most reliable sign. There's a little bit of cartilage that lives over here and can fake you out sometimes. Um, the big tears tend to happen proximally. The T sign is just one of those things that just keeps getting passed down. I think we can move on from it. But looking closer to where the common flexor tendon is and deep to that is the UCL. So how do you repair the UCL? You've got multiple bands in there. It's just a complicated structure on the medial side of the elbow. And so they've come up with a lot of these different kind of tunneling techniques for doing it. They're kind of colloquial known as Tommy John surgery, but of course there are very different varieties of it and techniques, but the whole goal is to restore the anterior and posterior bands of the UCL. So sometimes they'll leave these two things separate, sometimes they sew them together. So what does the repaired UCL look like? Well, similar to the rotator cuff, it looks pretty wild. There's always this susceptibility that's going to obscure everything and very difficult to figure out what is going on. And this is a problem that can be solved much better with arthrography compared to the rotator cuff because there should be much less of a gap in that repaired ligament and it should hold contrast a little bit better than what we see in the rotator cuff. But you're going to have a lot of these holes where we've drilled through. That's in the coronoid process, the medial epicondyle, and they've kind of just weaved these tendon grafts, sometimes palmaris longus, and they just kind of weave it through there and reestablish a UCL. These, this one is a great example of where you've got a little bit of fluid in there, but it's still watertight. Another common issue around the elbow is ulnar nerve entrapment. Now, I don't know if any of you have ever had cubital tunnel syndrome or ulnar nerve entrapment, but it is miserable, so painful. And it's just this dumb little nerve that lives inside the cubital tunnel. And the cubital tunnel has this little retinacular portion, and then the deep part of it is our UCL. And we should have normal fat around it. It should be just kind of a nice looking nerve. So what does ulnar neuritis look like? Well, in a really bad case, that nerve's going to be big, it's going to be gray. Sometimes you get a little bit of stranding around it. If you zoom in on them, sometimes they just look exactly what you would imagine a nerve looking like. You got all your little fascicles in there, really big. The appearance of it does not correlate to symptoms. So you may see a big ulnar nerve and comment on it in your report and get a call and they're like, oh, they have no problems there. It's just, it's part of the ambiguity. Sometimes people just have a big nerve. So the way of kind of getting around the cubital tunnel syndrome and the mass effect on the ulnar nerve is to either decompress it by just cutting that retinaculum and giving it some space. Another common one is this subcutaneous transposition where they take the retinaculum and then they flip the nerve over almost like a bucket handle and get it out of the notch back there. And that tends to be helpful. But this and the submuscular decompression, once you start cutting lots and lots of soft tissues, the postoperative imaging gets really messy because you've got lots of granulation tissue in there and it can get a little bit scary. This was just an example of the simple isolated decompression. You've got some scarring back here and they've just kind of opened up that area for the ulnar nerve to be in. Sometimes you get these more elaborate surgeries where they've done a lot more work and it looks a lot messier. You've got all this scarring and susceptibility in there, but the nerve is actually all the way up here. So instead of living in the little cubital tunnel, it's been flipped over here. And this is the one time in my life where the sagittal actually showed me the ulnar nerve in like a long image. And if you look here, you can see this is where the nerve got flipped. So if you imagine a bucket handle, you could flip this back over here, and that's where it normally lives. So this is all the post-surgical changes. And they flipped the nerve over, and now we're just seeing it sitting on top of the common flexor tendon. So left some time for Q&A because I have a feeling we're going to have some questions. But I wanted to really emphasize these first two articles here. The Radiologist Primer to Imaging the Non-Cuff, Non-Labral Postoperative Shoulder, fantastic article. And likewise, this postoperative shoulder imaging. Both of these are just phenomenal articles. I used a lot of their images to supplement my talk just because sometimes people just do it better than you and you have to accept it. And I wasn't going to be able to make those diagrams myself. So, but the rest of these are also very wonderful articles, very they're the kind of articles that you save and put aside for when you come across some of these scarier post-operative examinations. And then a couple of images I took from RadSource and Radiology Assistant, two websites I also find to be pretty useful. That is it. Miriam, what do we have?
Wonderful. It was a great talk. Thank you. Definitely many good points to take home for me for sure. We have a few questions and thank you for putting the questions. And the first one is there any discussion of ortho using fitted prosthesis, fitted based on CT, similar to how the macro protocol fits the TKA individual patients rather than the coracoid donation? It just seems the coracoid only roughly approximate the glenoid from the lateral jet portion of the talk. So, Greg, what do you think?
Um, I've always wondered kind of along that same line. Like it just does not look normal. It looks like someone just slapped it on there, like the guy from the infomercials where there's a hole in a barrel and water's pouring out, and he just slaps the piece of tape over it. That's how I feel the ladder J procedure is like cut off the coracoid, push it on there, and the morphology doesn't really matter. What they really need is just to increase that surface area enough to reduce the chance of, it coming out again. I'm sure that there are people trying to come up with a more kind of CT generated graft model for things like this. Um, I'm not sure if it'll have better outcomes or not. It looks like a kind of a sloppy surgery, but it seems to have pretty decent outcomes.
Yeah, I saw they use the CT filled glenoid a reconstruction for the failed lateral J, or the ones that they had a lot of loss of the bone in glenoid, and the coracoid is not going to fill the hole for sure. I saw that one, but not the initial one, or to my knowledge, I don't know that they are doing it anywhere as standard of care. But for sure, I saw few revisions for failed large A or very huge defects in the glenoid. Okay, we have another questions. Thank you for a great talk. Do you know why there is superior migration with some full thickness rotator cuff tears and not others?
Um, I don't know the answer to that. I've seen it a million times, but I've never really stopped to think about it. The cuff is not the only thing holding the humeral head down. You've got your coracoacromial ligament, There's a lot of other structures that live in that area that just, you lose one of them and things just start kind of moving, migrating. But I think for the humeral head to be like visibly superiorly migrated, I really think you need some degree of cuff tearing, in addition to, a ligamentous issue.
Okay. Yeah, I agree. I don't think that just the tear of the tendon is sufficient for movements. Probably the rest of the cuff or so other supporting structures are torn with it. Yeah, good questions. Another question is regarding the elbow. The ulnar nerve often normally has some increased signal. Do you also require enlargement before calling abnormality?
Yeah, the ulnar neuritis is kind of like adhesive capsulitis, where you're like, I think they have it. I don't know if I want to put my neck out and say it. And you kind of search through Epic, like, oh, what kind of symptoms do they have? And then you can kind of make it fit. The only thing that I have found convincing with ulnar neuritis is abrupt changes in the size and signal. So if you look before you get into the cubital tunnel and after, if that looks different than the rest of the nerve, then I call that ulnar neuritis. If it looks uniformly thickened and a little bright, and bright enough, I mean by, is the referring surgeon going to see it? Um, then I'll just say it looks a little bit big and bright. And I won't really come down hard on it. But I think that the change in contour signal in a short segment is slam dunk.
Yeah, I agree. I think I use that one, that point for any other neuritis as well, because
Yeah.
in the lumbar plexus or any other nerves, it's very helpful because it's just bundle of like, nerves are coming out and it's hard to call them. Okay. We have another question of the elbow. How do you identify the different bundles of UCL and MRI?
Yeah, you just based on location of where you are on your, you put the coronal up and your axial, and as the slices go through, you figure out, I feel like I'm posterior now. The posterior band tends to have a more fan shaped, and it's got a little bit of intermediate signal to it. It just looks a little bit amorphous. The anterior band usually will be a little bit cleaner, but I mean, where the anterior and posterior bands begin and end, when does a cute pickle become a pickle?
Yeah, but just like, I do this thing, just like, hopefully if the patient doesn't move and I just go by the location. And if it's a correct, like, plane and sagittal, then we can, based on the location, we identify them. We have another question. Thank you for the awesome lecture. My question is in MR, for the MR shoulder. Is the MR shoulder of limited value of labral and tendon tears for post-op shoulder? I ask this question because MR arthrogram is usually not available in our setting. Thank you.
Um, I, I don't think that the MR arthrogram for the cuff is really answering a lot of questions. We just sometimes will get questions about it from the refers, and it's just, it really comes down to if there's a specific part of the tendon that we're looking at and we really can't figure out if it's torn, then maybe arthrography is going to help. For the labrum postoperatively, I do think that MR arthrography is very important. I think, period, the labrum needs arthrography. You look at all these non-arthrographic MRIs of the labrum, and you pick up labral tears here and there, but I'm sure there are many that are slipping through the cracks. So my feeling is if there is concern for a labral tear, and orthopedists tend to be fantastic at differentiating these things, a cuff versus labral injury, usually. And so if they have a very specific question about the labrum, I go with arthrography.
Perfect. Okay. I have a question too, Greg, myself. So do you guys use CT arthrogram for the post-ops regularly or?
Not regularly. We just did one the other day, and I don't know. It it was it kind of gave us a good look at the repaired tendon, but I don't know how much it helped me.
Yeah, we usually use it when it is lots of metal and we cannot really use any metal suppression technique, and it's the whole black hole in the MRI. And we do the CT, and usually kind of like, the orthos based on the radiograph or based on the history, they may order a CT orthogram. But you're right, it's not very satisfactory. It is good for the articular surface tears
Yes.
and obvious labral tears, but otherwise, I didn't find it very helpful for
Yeah.
other details.
I'm not sure what the reason is behind all of the susceptibility you get on those post-op rotator cuff MRIs, because it's not like they're stapling stuff together and putting in metallic screws. It's just all of these little flecks from when they're debriding and cleaning up the subacromial decompression and stuff like that. Just little bits of metal come out, and man, they really cause problems on the MRI.
Yeah, correct. And yeah, and some of the softwares does help, but to me, it's very tech dependent, and also like who is implementing the software and the physicist. So uh, each location can have their pitfalls.
Yeah, exactly. They may end up at the scanner that's 30 years old.
Yeah, exactly. Okay. I don't see any other question. And with that said, we just want to thank everyone for joining us. And we also want to say thank you to our wonderful support team in SSR, make this webinar goes very smooth. There's a survey link in the chat. Please, and also we'll send it to your email. Please give us feedback. We use that to improve our lecture series. And our next resident education club webinar would be in November 12, and it is on plantar plate tears and differential diagnosis for metatarsalgia, which will be presented by Dr. Atul Taneja. Hopefully, we see you then, and hope you enjoy the rest of the day or evening. Thank you.